If you guys can scan the QR code or the link at the bottom, it'll go to something called Poll Everywhere. I can't toggle between the two, and I couldn't put the software on here, but it'll come to me and I'll activate questions as we go throughout so that you guys can participate. As a forewarning, I tend to talk fast anyway, and then if you put me in front of people and make me nervous, I talk even faster. So if I start to go too quickly, please slow me down, please ask questions, and hopefully we'll learn something today. Everybody good on the QR code? I'll give it one more second. It's about as technologically savvy as I get, so. All right, so our learning objectives today are pretty straightforward. So we want to accurately diagnose high blood pressure using office and home-based measurements. We want to be able to counsel our patients on lifestyle modifications, and I feel like that's been a theme throughout today's lectures. So talking a lot about diet and exercise. We want to identify an individualized recommendation and treatment plan based on our patient and their comorbidities. And then we want to identify those patients who need a secondary workup for their hypertension when it's difficult to manage. So it's important for many different reasons, but kind of listed here just tells you about the prevalence of high blood pressure in our country. So it's the leading cause of death in about 665,000 people, and it's our #1 modifiable risk factor for cardiovascular disease. Nearly half of the adults that we have high blood pressure, and that's about 1.4 billion adults aged 30 to 79 worldwide, and about 33% of the people in that age group. So there is a disparity, so it's more common in men than women. There's also some disparities in socioeconomic factors, also racial disparities that happen. And then there's about 600 million people that have high blood pressure that don't even know that they have high blood pressure. So screening becomes very important. All right, so we're gonna start kind of basic. So how do you diagnose and screen for hypertension in the first place? Who do we look for? So we're gonna start with a case, and this is gonna be the first time that our QR code comes in. So this, I used all real patient case scenarios. So these are all people that I've seen. So this is a 45-year-old African-American man presented to clinic to establish care. He has no complaints, he just hasn't seen anybody in about 10 years. He didn't have any issues or symptoms, so he didn't come in to be seen. No over-the-counter medications, no prescription medications other than some ibuprofen intermittently. Everybody's into pickleball, so that's what he's been doing. His father died of an MI at 75. His vital signs are listed, so you can see blood pressure slightly elevated at that 138/88. He does fall into the class 1 obesity with a BMI of 32. Otherwise on exam, he's just obese. Otherwise, it's pretty unremarkable. So this is gonna be kind of a word cloud. You can type whatever you wanna do. What would you guys want to talk to about with this patient? Lifestyle changes. Stop ibuprofen. Recheck some labs. We want to discuss weight. We want to talk about home monitoring, lifestyle. I wish I could bring this up, so the more that people type the same thing, the bigger it gets on my word bubble. So most of it is home blood pressure monitoring and lifestyle changes. So perfect. So who do we screen? So based on the USPSDF, adults over 18 or older in the office should have a blood pressure measurement. So this is a grade A. I will do the caveat, I am an internist by training. I haven't seen pediatrics in a very long time, but everybody, according to the American Academy of Pediatrics, should be screened for blood pressure starting at the age of 3 as well, and that's a grade 1 recommendation. So how do we measure it? So on this slide, and I think a lot of people already know about it, is the validatebp.org. So that has home blood pressure monitors that are recommended from the AHA and the ACC, along with monitors that we can get for our offices. And ideally, we want our patient to be sitting on a chair, feet flat on the floor, back well supported, arm resting at arm height with the appropriate size cuff on their arm. They should be resting for 5 to 10 minutes. Our appointment times are 15 minutes, so just keep that in mind. They shouldn't be playing on their phone, they shouldn't be talking to people, they should truly be resting. So that's how we diagnose or screen for high blood pressure. How often does that actually happen? Great, not very often, right? We usually take our patients from the waiting room, we walk them right back, we check their blood pressure. It's mildly elevated, they tell you it's fine at home. So what do we do from there? So if we're not doing great in the clinic, mostly we don't have time. We have 15-minute appointments with most of our people, and they're supposed to be resting for 10 minutes without us talking to them for a good portion of that. So home measurements can be vitally important. So Validate BP, like I mentioned, has those home monitors. There's different costs associated with all of them, so it puts our little number signs there. And then there is ambulatory blood pressure monitoring that we can do as well. So the picture up here is what that device actually looks like. It almost looks like my little microphone that I have on right now. However, these are not very available. Has anyone ever been able to get one in Charleston? I tried recently. We couldn't find one in the entire city.
There is one at MUSC.
Oh, we tried MUSC, so that's exciting.
They have one at MUSC, but the patient has to see the doctor and he has to decide to use it.
Okay, so that's helpful.
So it's not really available.
Thank you. So that explains why I couldn't get one. But ideally, we can have our patients have those validated monitors at home. We talk to them about how we're actually supposed to be checking their blood pressure. And then Epic is nice because it has that nice little feature where you can order a home BP monitoring chart, and the patient gets it, clicks on a link that brings them to it, and they can upload their blood pressure measurements. Started using it more often personally, and it's nice. You just get a little list of blood pressures. You can touch base with your patient, say these look great at home, and you don't change anything. All right. What evaluation do we need to do with people? So what labs do we need to do? I'm an internist. I like data. I like to get information, and this is the information that we usually need. So we need to get a fasting blood sugar, really screening for diabetes and the comorbidities. We want to get a CBC, mostly looking for polycythemia. You want to get your lipid screening so you can calculate your ASCVD or your PREVENT score. You want your GFR, you want your electrolytes, you want your thyroid, you want to screen for protein and hematuria, so you get your UA, and then you get your urine microalbumin creatinine ratio. Some of the optional testing, depending on your patient presentation, you can get an EKG and you can get an echo. It just depends on the patient's presentation. So a lot of these are labs that we're going to be getting anyway. All right, back to our patient. He's been monitoring his blood pressure at home. It's been average in the 138/84. He did get his blood work done, so his GFR is great. It's 102. His potassium is a little below 4. It's at 3.7. Blood sugar is 87, and his A1C was 5.6. CBC, thyroid is all normal. Cholesterol panel is a little bit abnormal with an LDL of 150 and triglycerides at 250. UA was normal, and there was no proteinuria. All right, so that's his stuff. So would we want to start him on medications? So this comes back to that lovely diet and exercise that we've been kind of talking about all day and with every disease process that we've had. So we would want to start him on therapy if his average blood pressure is consistently in that 140/90. You can also calculate the PREVENT score. So the ASCVD score you can use in Epic. You just do your .ASCVD, it'll calculate it for you. The PREVENT score is not in Epic, but you can pull it up easily, and I calculate it all the time. But it gives you a 10-year risk of heart attack and stroke, and it also calculates your 30 or lifetime risk of cardiovascular disease. So cutoffs are still the same at that 7.5. And then if they have diabetes, chronic kidney disease, or if they've had cardiovascular disease, those are the patients you want to start on therapy. So if they don't quite meet that criteria, and then they're in that class 1 hypertension in the 130s/80s, you can work on lifestyle for 3 to 6 months. So what does that lifestyle mean? We keep saying people need to work on their diet and they need to move more, but how do you tell people to do that? This kind of comes back to what I did before I did medicine. I was an exercise physiologist, so I used to force people to exercise. Mostly they would come to see me anyway. They wanted to do things, but I would make them do it. So we want to work on weight loss. And the best way to do that is by making people move and making them watch what they're putting in their mouths. So when we're talking about blood pressure specifically, the DASH dietary pattern, so I don't like to use the word diet. Diet, I feel in my brain, has a negative connotation, and it almost feels like punishment. So when you tell your patient they have to go on a diet, it seems bad. So you talk more about lifestyle. So it's not necessarily restrictive. So the DASH diet really is similar to the Mediterranean, but it also really focuses on sodium intake. If they're able to consistently follow that, they can actually lower their systolic by about 11 millimeters of mercury. So that's about as good as medicine. So it's a huge change. If you can also work on increasing potassium and decreasing sodium, you can lower your blood pressure. This is kind of an example of what the DASH eating plan is. So I think it's the things that we all know. It's just making sure that the patients have the resources to know how to find these things. So it's fresh fruits and vegetables, your lean proteins, your low-fat dairy, fish that has the good fats, poultry without skin. We fry a lot of chicken in Charleston. It's delicious, but the skin is where the fat is. Your beans and your legumes, your nuts and your seeds, and then limiting the things on the right side of the chart. All right, how about exercise? So we want to talk about both aerobic and then resistance training. So when we talk about minimum recommendations for exercise, usually that's going to be 150 minutes a week of moderate activity. Does anyone know how to describe moderate activity to a patient? Is it them walking their dog? Dog stops every 5 minutes to pee. Chasing their kids around the house. Dr. McMonagle's staring at me because I asked him to participate. How do you say moderate physical activity?
Either go by heart rate, but that's hard for a lot of patients. Usually, if they're able to have a conversation and say a few words at a time, but not be able to sing, that's usually moderate activity.
Yep, and it doesn't all have to be at once. So it doesn't have to be 30 minutes straight. You can do 10-minute increments. You can do 15-minute increments. But with the advent of smartwatches, especially if a patient's committed, that can help quite a bit. But it's really, you're able to have a conversation with somebody, but if you tried to sing a musical, you wouldn't be able to do it. Vigorous cuts that requirement in half, and that's really like your HIIT classes where you can't say more than 2 to 3 words at a time, heart rate's very elevated. And those are minimum. So that 150 or 75 is minimum for cardiovascular benefits. And we want to add resistance training at least 2 to 3 times a week. And I always like to say with resistance training, it does not have to be powerlifting. You don't need to go to the gym and pick up 50-pound dumbbells. It can be body weight exercises, but adding the resistance training, incorporating upper and lower body, that amount of time will also help with blood pressure, also help with muscle mass long-term, and maintaining your bone density. And then alcohol has come up several different times. So I know old school thinking, or what I used to think about, 2 drinks a day for men, 1 drink a day for women. None is better than any. So if they can abstain completely, it's always going to be better for you. All right, so here's some examples of how you can kind of incorporate physical activity, and it gives you different ways that you can divvy it up as well. So if you look kind of in example 1, you're going your straight 30 minutes 5 times a week, and then you're doing 2 days a week that work all of your muscle groups. But again, you can change it up a little bit. You could do like your intense activity a couple days a week, moderate on the other days. And then if you get somebody who's really interested in exercise, try and do bodybuilding, they'll do backs and bis, chest and tris, lower body one day, you mix it in. Children, again, caveat, they should do at least 60 minutes of moderate to vigorous physical activity a day. So that was the Play 60 that came out a while ago. I know a lot of children don't get this unless they're in organized sports anymore, so encouraging our children to just get out and play. All right, meds. Why do we do meds? Again, I'm an internal medicine doctor. I love medicines when they're necessary. So for every 10 millimeter decrease in systolic blood pressure, you can reduce somebody's risk of stroke by about 60%. And then every 20/10 increase in your blood pressure doubles your cardiovascular mortality. I think a key piece in terms of pharmacotherapy is if you add a second dose, like moderate dose of a second medicine, rather than just increasing dose slightly in the first, you're going to actually be 4 times more effective in lowering somebody's blood pressure. So sometimes 2 medicines at a moderate dose is better than 1 at a higher dose. All right, we're back to a case. Let me activate my little thing. Thank you for being patient. I am not great with technology. All right, we should be activated. Great, so we have a 32-year-old female. She's 6 months postpartum. She's still breastfeeding. She had gestational hypertension, was on nifedipine, but she stopped it because her blood pressure is better. Today in clinic, 142/100, similar at home. What would you want to start? And I'm pretty sure everybody's going to get it right. It's a pretty easy one. We're starting off easy. Pretty much everybody said A, so nifedipine. She did well on it before. It's safe in breastfeeding, and it's still one of our first-line therapies for blood pressure. So perfect. All right, we're going to go straight to another case. All right, so we have a 50-year-old obese male. Hasn't been seen in 10 years, wasn't having any problems. I feel like this patient comes into my clinic a lot. His blood pressure measured appropriate in clinic. We had extra time. He was able to sit for that full 10 minutes, not playing on his phone. And his blood pressure is 160/98. Heart rate was normal. BMI is just into the morbidly obese. He drinks 2 to 3 drinks most nights and smokes 1 pack per day. There was no labs available, but we do have a previous blood pressure that had an even higher blood pressure measurement when he's seen in Express Care. Other than telling him to cut down on his alcohol and nicotine, what else do we want to do? And some of my questions can have more than one right answer, so it's not a board question. We're kind of split, not quite 50-50, between B and C. So either starting amlodipine monotherapy and really working aggressively on lifestyle, or starting combination therapy with ACE, ARB, thiazide, calcium channel blocker with lifestyle. So both of them could be appropriate. So it just really depends on your patient, what they're willing to do in terms of side effects with medications as well. All right. Yes?
I was just going to say, I take care of a lot of African Americans, and I use this genetic test called the lipoprotein A. And, you know, if it's over 75, and I've had a lot of people, you know, like with the first case, they see it in bright red, and, you know, it's like 200, and they're like, Jesus, you know, I don't want to have a stroke or heart attack in the next 5. So they really come back, you know, with the turnaround.
Yeah.
And they see that versus, you know, adding medicine.
That's more for statin therapy rather than, because you would do lifestyle for both things.
Yeah, so, you know, it reduces your risk of stroke,
Mhm.
attacks everything, you know. So, you know, as, you know, blood pressure, you know, causes CAD, stroke, supplements, I think, you know.
And that's why lifestyle is also in there, because lifestyle is also going to aggressively change the lipid panel. Some lipid disorders are genetic, so some people will not be able to avoid medications to a certain degree, but a lot of those have similar risk factors, and at baseline outside the pharmacotherapy will be treated very similarly. So everybody needs to move and everybody needs to eat right. All right. So first-line agents, so we actually have technically 4 different classes that are considered first-line based on the current recommendations. So we have our thiazide-like, which are usually the HCTZ and chlorthalidone. So all of my tables have slightly different things on them. So just because my thiazides have this one, my ones with calcium channel blockers have a little bit different information. Tried to make it as what will be used most in clinical practice. So with HCTZ and chlorthalidone, really indicated for end-stage liver disease patients, nephrolithiasis, and your hyperkalemia. It's contraindicated in pregnancy. End-stage renal disease is questionable. Can precipitate gout flares. And then the big thing that we probably see clinically is the hyponatremia. Much more likely with the chlorthalidone, it's a more pungent drug. Chlorthalidone was also in most of the blood pressure studies rather than HCTZ, has a much better half-life. So ideally we'd be using chlorthalidone for blood pressure. But again, we got to recheck our metabolic panel, make sure we don't make our patients hypokalemic or hyponatremic. I can think of like 2 in the past couple weeks that I've had actually. Then we have our dihydropyridine calcium channel blockers. So this is another common thing. I've done a lot of resident and medical student teaching, and sometimes we have difficulty telling between dihydropyridine and non-dihydropyridine. So really for blood pressure management should be our dihydropyridines. So indications, pregnancy, that's our nifedipine that we had in our previous question. Also okay in breastfeeding, Raynaud's phenomenon, and then you can also use things for like CVA, intracranial hemorrhage and press. That's more in the inpatient side. That's your cardine drips in the ICU. And then contraindications, I put a question mark by swelling. Does anyone know how common it is to actually get swelling from things like amlodipine? It's at least 10%. And it is dose dependent, so the higher dose that you have, the more likely it's going to happen. I've seen some pretty rampant swelling in some people too, where their ankles are huge. Thankfully it goes away, so that's the good piece about it. Does it really respond well to thiazides? If you put somebody on a diuretic, does it get better? Not usually. ARBs can actually make it a little bit less, so sometimes those combinations will work well together and you'll get less of the leg swelling. All right. We talked a little bit about this already. Again, chlorthalidone is preferred, but it is more pungent, so you have more of the hypokalemia. I've never really prescribed indapamide, but it's in there in your toolbox in case somebody really wants to be on indapamide. Then our dihydropyridine calcium channel blockers. The big ones that we usually see are going to be your amlodipine and your nifedipine. There's also the nicardipine. Again, that's more the inpatient drip or TID dosing in the outpatient setting. Most TID dosing isn't very reasonable for patients. Most people can't remember to take a dose once a day, rather alone 3 times a day. So really it's going to probably be between amlodipine and nifedipine extended release. So amlodipine is nice. It doesn't kick in very quickly, so it takes 24 to almost 72 hours. And then it also lasts for that long. So if a patient misses a dose intermittently, they shouldn't really have too much rebound. And it doses anywhere from 2.5 to 10. And again, dose dependent on the swelling. And then nifedipine ER, which is also Procardia, dosing between 30 and 90 a day. In the IR form, again, you can get some rebound, so it does increase risk of hypotension. So typically the ER form is preferred. All right, let's go to our ACEs and our ARBs. Full disclosure, I haven't started somebody on an ACE in many years, actually, because ARBs have less of the angioedema. So ACEs I haven't used very much, but they have very similar indications. So indications, heart failure through juice ejection fraction, just like mentioned from Dr. Pinto. Post-MI, chronic kidney disease for renal protection, and then microalbuminuria because it can help protect your kidneys. Should not be given in pregnancy. Bilateral renal artery stenosis can cause angioedema, hyperkalemia, and cough. So the ACEs with the bradykinin that builds up where it hits in the pathway, that's where you get your angioedema and cough from the bradykinin buildup. Not really seen in ARBs, which is why I prefer them clinically. So everything, ditto to ACE, other than there's specific classes or medications in the class that is not class effect, it's really specific to them. So losartan, if you have really bad gout and it's not well controlled with allopurinol, it is uric acidic, so it can help lower your uric acid level. Candesartan, which was a new one for me and I may start using more, is actually indicated for migraine. So I know we tend to use a lot of beta blockers for patients with migraines and hypertension, but candesartan out of the ARBs actually is indicated for that as well. So it might be something we could try instead. No cough and then no angioedema. And you can start ARBs in patients who have had angioedema after you let it wash out. All right, so what are our ARBs? There's lots of different ones. I've seen most of them in clinical practice. Here I listed more potency, so which ones are going to have the biggest bang for your buck in terms of lowering your blood pressure. The most common one that you'll usually see is losartan, but it's actually the least potent. So if you're truly using it for blood pressure management, twice daily dosing is usually preferred because its half-life is a little bit shorter. You also have your valsartan, nice kind of middle of the road in terms of potency. You also have irbesartan, telmisartan, candesartan, which I just mentioned, quite potent, and you can also use it for migraines. Olmesartan is one of the top ones, and then azilsartan, which I think I have one patient on, is the most potent of the ARBs. We also have our ACE inhibitors. Again, they've been around forever. So lisinopril is probably the most common, nice 24-hour, once daily medication. We also have enalapril, ramipril, benazepril, and quinapril. Most of them are very similar, other than enalapril, which can be usually divided in about twice daily dosing. Excuse me. All right, what are our second-line therapies? So we have our aldosterone antagonists and beta blockers. Again, some of these will probably look familiar from Dr. Pinto's lecture with heart failure. So with spironolactone and eplerenone, indications, chronic kidney disease, end-stage liver disease, PCOS, specifically the spironolactone because of its effects on the testosterone receptors, and then hormonal acne. Contraindications, hyperkalemia, again, spironolactone with a gynecomastia, and shouldn't be used in pregnancy. There are tons of indications of beta blockers. So post-MI, end-stage renal disease, aortic dissection in the hospital again with esmolol, esophageal varices, tachycardia, anxiety, essential tremor, migraines, pregnancy. So the list goes on and on. In terms of contraindications, elderly, if they become bradycardic and fall, and then asthma depending on the specificity of the beta receptor it hits. All right, other second-line therapies are your alpha-1 agonists and your alpha-1 antagonists and alpha-2 agonists. So things like prazosin, good for BPH and PTSD or nightmares, so dosing at nighttime. It can cause the hypotension and dizziness, so usually dosing at nighttime helps. And then things like clonidine are not my favorite, mostly for the reflex hypertension that goes along with it. So it's usually twice daily dosing, you'll get your reflex hypertension. It does come in patches, so if you don't have any other options and you're still not controlled, it could be a potential use. And we also use it in opiate withdrawal and anxiety. All right, our beta blockers, which ones are we using? I did these ones based on the beta receptor that they're gonna hit. So we have our atenolol, which is one of the first blood pressure medications and what everything was kind of gauged upon. And we also have our metoprolol, and there's 2 different kinds. We got our propanolol, bisoprolol, carvedilol, and labetalol. So if we're looking at the type of receptors that they hit, atenolol and metoprolol are mostly beta 1. So if we look at the side effects with those, it's really going to be the bronchospasm. And then for the metoprolol, just like Dr. Pinto mentioned earlier, succinate and heart failure, not tartrate. Propanolol is good for essential tremor and migraine. The most specific ones, if we're in terms of blood pressure management, so if we're using a beta blocker for blood pressure and no other indications, usually it's going to be carvedilol or labetalol because they also hit the alpha-1 receptor, so they're a little bit better at lowering blood pressure in that instance. All right, we've got another case. Let me get back on here. All right, so a 40-year-old male presents for hypertension follow-up. We started him on chlorthalidone last visit, got some repeat blood work, and on his metabolic panel, his GFR went from 102 to 95, and his potassium dropped pretty precipitously from 3.6 to 2.9. Blood pressure at home is still averaging in that 146/88, and in clinic today, he's 140/85. Again, there can be more than one right answer. So far, 100% say D. Oh, we got some going C. We're 50-50. Right, so some people want to stop chlorthalidone and change to a calcium channel. Some want to stop chlorthalidone and change to dual therapy with calcium channel and ARB. Anybody else want to speak up for their decision? Anybody have strong feelings about any of them? Okay. All right, so this is another case. We'll talk about what we're going to do on the next one. I would have done D. So for this one, we have our 40-year-old female. She presented to established care. Her blood pressure when she came in was 169/119, measured appropriately. At home, she says she's always greater than 200. She's asymptomatic, states it's normal for her, has been dealing with hypertension for 20 years. She had amlodipine, clonidine, doxazosine, carvedilol, HCTZ, and chlorthalidone all listed. We did call her pharmacy. She had only recently filled clonidine, amlodipine, and doxazosine. Carvedilol, HCTZ, and chlorthalidone all hadn't been prescribed for 6 months, and she has an allergy to ACE. Bubbles. What do you guys want to know? She didn't bring any meds with her. She doesn't actually know what she's taking. She goes, I don't know, I take 3. You can yell out answers too. Anybody? Mm-hmm. Especially if I don't know what they're taking. For this one, I wanted her to come back and bring all of her medications in. That's what I was like, bring a bag with everything in it that you have at home. Do you think this patient would have needed a secondary workup? Most likely. Somebody had her on a whole bunch of different classes of medications that weren't necessarily first line. Don't know what she was actually taking, but it seems like she was still uncontrolled. All right, so based on the AHA and ACC, for resistant hypertension is defined as a blood pressure above goal, despite 3 antihypertensives of different classes, including a max tolerated dose of a diuretic. So if that person exists, then they deserve a secondary hypertension workup. And special attention to hyperaldosteronism. So it's actually more common than what we diagnose. And usually it's about 20 to 35% of those resistant hypertensives have hyperaldosteronism. So we should look for it in resistant hypertension. If you have spontaneous or diuretic-induced hypokalemia, like in our one case earlier with our gentleman who dropped his potassium. If they have an adrenal incidentaloma, so now everybody goes through the tube of truth in the ER, and we're all stuck with these adrenal adenomas that we don't know what to do with, but they all deserve a hormonal workup. If they have sleep apnea, unexplained atrial fibrillation, or a family history of hyperaldosteronism. So this lady, we did get some blood work on her. We said, bring back all of your meds, let's get some blood work. Sodium was 137, her potassium was 5.1, chloride of 102, her CO2 was 22, blood sugar is normal, BUN 23, creatinine was 2.1, and her eGFR was 29. So she's got some nice chronic kidney disease. Her UA did have proteinuria, but we had no other prior urine microalbumin or creatinine. We ended up getting an echo on this lady, and I'm sorry I don't have an E to E prime. I should have put it on here. Dr. Pinto would be destroyed. But her EF was 55 with grade 2 diastolic dysfunction. And we did do a secondary workup on this patient. So we did also looked for pheochromocytoma, which was normal. Her renin was suppressed, but her aldosterone was normal. And this was her EKG. So thankfully, not the worst. All right. So how do you actually interpret a test for hyperaldosteronism? So as you can see on the side here, it does have your algorithm with it, and there are some medications that can affect interpretation. So if they are on any of those medications, it is always worth retesting, but you can test people who are on ACEs and ARBs. When you read the guidelines, you should really only try to titrate people off and let it wash out if it's safe to do so. So if the patient's blood pressure is 200, it may not be safe to let those medications wash out just to get a test. It is positive if you have your suppressed renin less than 1 and your aldosterone greater than 10. If you're in that borderline and you still really think that somebody has hyperaldosteronism, it does bear repeating. Okay, so again, hypokalemia can interfere with your assay. So if the patient is hypokalemic when you get your renin and aldosterone, you should repeat it with a normal potassium. Again, if they have high pretest probability, but their results were negative. And then if their renin is low, but their aldosterone is in that borderline 5 to 10 range. All right, last one. So we have our 52-year-old female. She presented for hypertension after some home measurements were high. She did have a headache, and that has since resolved. Blood pressure when she came to see me was 207 over 120. She was started on losartan and HCTZ with ER precautions. We did that medication based on risk benefits and what she was willing to deal with in terms of side effects. She did not want a calcium channel blocker. She didn't want to swell. Sodium was 136. Her potassium went from 3.6 from 3.9. Creatinine stayed okay, and her urine was negative for microalbuminuria. In follow-up, despite those medications, her blood pressure is still 166 over 88. So we did get a secondary workup on her. So if you can see, her renin is much less than 1, and her aldosterone is elevated 19.7. And she actually did have a CT scan that showed slight thickening of the left adrenal gland without a discrete nodule. So she had hyperaldosteronism. So with the help of endocrine, you can also talk with nephrology. We started her actually on spironolactone and have been slowly increasing dose. So last time I checked in with her, she was in the 140 range. So much better. All right. I wanted to include this on here mostly for patient compliance. There's lots of combination medicines that we can use. So instead of just putting somebody on amlodipine and then adding olmesartan later, there's lots of different medications that contain the medications. It makes it easier for compliance. So instead, it's always easier to take 1 pill than 2 or 3 pills. So if you can combine them for patient ease, it's much better. And most of them are generic now. So in terms of cost, it's much better than it used to be. All right, questions? Hopefully I didn't talk too fast.
No, you did
Okay.
not. You did a great job. We can, you're going to be here to the end, so we can maybe hold all the questions to the end.
That's fine by me.
We have Dr. Woodfield to talk about renal vein denervation.